Good evening, everyone. I am Dr. Savitri Dotto, Coordinator, Internal Quality Assurance Cell of Ddmrm Motichil Robindra Mahavidyalaya. First, I convey my warm greetings on behalf of our college to all present over here. We have with us our rector and all honorable IQAC members and participants from different corners of the state and other parts of the country. We are delighted to have each one of you. The gracious presence of all of you present here is the main motivation for us organizing this program. Now, non-communicable diseases such as cancer are on a steep rise. They can severely burden our country's economy and cause a drain on developmental financing. The fact is, cancer treatment is costly, and development of a national cancer control strategy might be a challenge for many nations. This fact is of great concern to all of us. Cancer has long been a greatly feared disease that touches lives in deeply personal ways. Today, cancer touches every country in the world, sometimes in deeply disturbing ways. And this is especially true when we look at national differences in the cancer burden, differences in access to treatment and care, and above all, differences in the outcomes and survival rates. This time, cancer should be a development priority. Cancer contributes to poverty and impedes development. Diseases like cancer are a leading cause of so-called catastrophic health expenditure. And this is especially true in the low and middle income countries where most people rely on out-of-pocket payments for their healthcare. WHO estimates that catastrophic payments for healthcare push millions of people below the poverty line each year. For cancer, out-of-pocket expenditure is a double-edged sword. It discourages people from seeking treatment early when the chances of cure are the greatest. And secondly, it depends household and the community poverty. In our country, India, the incidence of cancer is increasing rapidly. Therefore, it is important to step up cancer literacy and knowledge amongst the population. Early detection is essential in its management and treatment. Now, due to ignorance, fear, and social stigma, many people present with advanced stages which require surgery and extensive treatment. If detected early, then in most cases, there will be less aggressive treatment and better chances of recovery. In this meeting, we'll all have the chance to know where are the gaps in our knowledge, what are the signs and symptoms that should make us report to the doctors, what are the available treatment and at what cost, and what are the stress and trauma related to this particular disease, and many more. So it is my pleasure to introduce our speaker today, Dr. Shoikat Gupta, Director of Surgical Oncology, Apollo Gleneagles Cancer Hospital, Kolkata. He completed MBBS with a gold medal in 1992, and he secured second position in MS, although his thesis was accredited as the best. He has honors in surgery, gynae obstetrics, pharma, followed by numerous college prizes and medals, which includes Sir Frank Conner Memorial Award in surgery, and also Sir Girish Chandra Ghosh Silver Casket in pathology. He is specialized in the field of oral, breast, stomach, cervical, rectal, colon, uterine, and neck cancer surgery. Dr. Gupta is relentlessly pursuing the field of oncology for almost 2 decades. He was Chief Resident Surgeon, Department of Surgical Oncology, Tata Memorial Hospital, Mumbai. Dr. Gupta has delivered several lectures in various oncological conferences and seminars. He has attended several national and international conferences on cancer. In fact, his continuous effort to expand his knowledge base has always kept him updated in this fast-changing subject. So we are eagerly waiting to listening to Dr. Gupta. getting ourselves enriched and enlightened from Dr. Gupta. Before starting the session, I have to just make a small announcement that feedback link will be provided in the chat box during the session. Participants are requested to fill up the feedback form and submit it before the session ends. This is necessary for generating e-certificate. No further communication regarding the certificate after the webinar will be entertained. So we are waiting for listening from Dr. Gupta. Over to Dr. Gupta, please.
Hello, Dr. Gupta. Hello.
Good evening, Professor Das Gupta.
Okay, thank you. Most welcome in our webinar. Okay.
Thank you. So shall I start?
Yeah, of course,
Yeah,
sir.
Okay. So good evening, everybody. So first, let me clarify, the language of address should be in English, right?
Yes.
Okay. So, ladies and gentlemen, tonight we are here to discuss cancer, which is malignancy, pre and post-COVID era. And as Professor Dotto said, the various economic and other implications associated with this disease. So to begin, let me try to make you understand what cancer is. Now, it's very important to understand the basic thing about this dread disease, which is, to put it very simply, suppose when you have a cut somewhere in your body, suppose there's a cut in the hand, it heals, right? Tissues, how does it heal? Tissues grow out from the periphery of that cut, and the gap in that area, for example, the skin, becomes full, so it heals. So when there is such a damage in the body, wherever, there is a signal, which is a start signal, which tells cells to start dividing. And when that defect or that cut, for example, in the skin is repaired, there's similarly a stop signal, which asks the cells to stop dividing because the tissue is repaired. So it's all about this start and stop signal. So suppose somewhere in the body, maybe anywhere, be it in the breast, in the oral cavity, in the lungs, for no reason at all, there's a start signal and some cells start dividing. It may start from a single cell. And they go on dividing, and what they form is a lump of cells. And the stop signal does not happen. So there is a start signal without cause, and the stop signal does not come. So the cells go on dividing uncontrollably. And what forms there is a mass of cells, which when clinically detectable, which means you can feel it or you can see it in a scan, we can see it and we say that's a tumor. Now this tumor can behave in one of two ways. It can either be well-behaved, so to say well-behaved, and it can stay where it is. It can increase in size, but it does not invade surrounding structures, and it does not send its cells as its soldiers into the bloodstream or the lymphatic stream to go to other organs and establish colonies there. So when this tumor behaves in a good manner, it does not do these things, then it is called a benign tumor. Benign tumors are very common in the body. Young girls have lumps in the breast. Elderly ladies develop fibroids in the uterus. Many a time you will see lumps and bumps on your skin, skin tags, papillomas. These are all benign tumors. Benign tumors are not cancers. Now the tumor can also behave in another way, as I told you. It can go on dividing. Not only can it go on dividing, it can extend into other organs and invade them, which we call local invasion. And it can send its cells into the blood and the lymphatic stream to go and set up colonies in other organs and destroy those organs by multiplying over there. Now this is a malignant tumor. And a malignant tumor is synonymous with cancer. So malignant tumor equals cancer. Now this random progression that, for example, let's take one organ, let's say the breast. A group of cells start dividing and they form a lump. The lump becomes bigger and bigger and bigger when the lady can feel it. then it becomes so big that it either reaches the muscle inside or it reaches the skin outside. Somewhere during this progression, when it becomes 2 centimeter, 5 centimeter, bigger than 5 centimeter, the cells go through the lymphatics into the nearest lymphatic drainage system where the lymph nodes are. In the case of breast, this is the armpit or the axilla. Lymph nodes are there all over our body. Wherever cancer develops, the regional lymph nodes, the cells, cancer cells first go there, because these nodes are also the defense. So they try to arrest the cancer cells going to other part of the body, and in the process, these lymph nodes get involved. Anywhere in the head and neck area, the lymph nodes are in the neck. In the case of breast, they're in the armpit. So for different areas of the body, the lymph nodes are in different places. So as I was saying, it becomes bigger and bigger. In the process, it sends its cells to the nearest lymph nodes, and the lymph nodes become involved. Then the main tumor is increasing in size, and the lymph nodes are also increasing in size. Somewhere during this line, they go out of the local confine, from out of the main tumor, out of the lymph nodes into the bloodstream, and they go to other organs. For example, in the breast, case of breast, it can go to brain, lung, liver, and the bones. For all cancers, these are the commonest sites where they spread: liver, lung, bones, and brain, and they go to other organs. Now this natural progression where it becomes bigger and bigger and then goes to the lymph nodes and then goes on growing and goes to other organs, this natural progression, medical science has divided into 4 stages. So all solid tumors, all solid cancers, leaving aside blood cancers, all solid cancers have these 4 stages. So stage 1 is when it is very small and localized to that organ of origin. Let's take breast as an example. If it is less than 2 centimeter, localized to the breast, hardly you can feel it, or maybe very careful examination can reveal it. It's stage 1. Between 2 to 5 centimeter, it's bigger than 2, but still less than 5. It's in stage 2. It may or may not have gone to 1 or 2 lymph nodes in the armpit. Stage 3 is when it is bigger than 5 centimeter. And it's visible. Maybe it has burst through the skin. Maybe it has become fixed to the muscle. Even the lymph nodes in the nodes in the armpit have become big. Many ladies come with a complaint of a lump in the armpit first before they find one in the breast. So this is stage 3. And when the cancer has gone to other organs of the body, then it is stage 4. So for basically all cancers, stage 1 and 2 are early. Stage 3 is basically when it is called locally advanced. And stage 4 is when it has spread and it is called metastatic disease. Now it's all in these stages. In stage 1 and 2, if you detect the cancer, the chances of cure are high. In stage 3, it's less. And in stage 4, it is nil. So when it has gone to other organs, you cannot cure any cancer. Now, how do we know that we have cancer? As Professor Doctor said, that it is becoming an increasingly difficult problem in our society because the numbers are increasing, and the problem is not only medical, it is social, it is economic. There's a stigma attached to it. There's a huge financial cost attached to it. As we say that cancer does not only affect an individual, it affects a family. And the cost of treatment is also huge. And it does push many people below the poverty line each year. It's all true. So how do we know? So cancer gives out early symptoms and signs, and it's all about knowing these early symptoms. So if I come from above to bottom in the body, top to bottom, let's take the oral cavity first. Oral cavity cancers are very common in India because of the rampant use of oral tobacco. Even people who don't use oral tobacco can get it. So any non-healing sore or ulcer in the mouth. It can be in the cheek, it can be in the gums, it can be in the tongue, it can be above in the palate, it can be below the tongue in the floor of the mouth. So basically any non-healing, a sore which is non-healing over time, or people who've been using tobacco for a long time have this tightness of the mouth with white patches and red patches inside. These are called oral submucous fibrosis, the tightness. And these white and black red patches are called leukoplakia and erythroplakia. So white and red patches or ulcer in the mouth which is not healing, or any bleeding from the gums or something which is not going down with time. These are the symptoms of oral cancer. Sometimes the cancer itself is small and it manifests with a lymph node in the neck. So a painless lump in the neck. Painless lump in the neck is another common manifestation. Any hoarseness in the voice, which we call gola boshe jawa in Bengali. Any hoarseness in the voice, which is not subsiding beyond 2 weeks. Any difficulty in swallowing or a foreign body sensation in the throat, in the back of the throat. Bleeding, which is not going, happens quite frequently. Suppose you have bleeding from the mouth, bleeding anywhere. Let's say bleeding anywhere, bleeding from the nose, bleeding from the mouth, bleeding from the nipple, vomiting in the blood, cough with specks of blood or blood in the cough, blood in the stool, blood in the urine, or in ladies after periods have stopped in the postmenopausal area, abnormal bleeding starts again. So bleeding from anywhere. Then coming back to the oral cavity, difficulty in swallowing. The food tends to get stuck. Then any acidity, which is not going away with time, can be a symptom of stomach cancer. Breast, very important, one of the commonest cancers in women. A painless lump in the breast or in the armpit. The lady may feel the main lump first, or the lady may feel the lymph node first. Bleeding from the nipple. Usually breast cancer's initial stages are not painful, but there are many young girls who have pain in the breast. In most cases, it is not cancer, but it definitely warrants suspicion because cancers also can start with pain in the breast. So that also should not be ignored. Although in most cases, it starts as a painless lump, it can start as a painful lump also. Any ulcer or sore anywhere on the skin, which is not healing with normal ointment application and all that. A mole or a beauty spot, which we call black spot, anywhere in the body which is newly appeared, or an old beauty spot which is changing character. For example, it's becoming bigger, or it's bleeding, or it's itching, or there's a blush around it. Rectal bleeding, bleeding in the stool. This is one of the commonest causes of colon and rectal cancer. The problem is that it tends to be treated as piles or fistula or fissure for a long time before some doctor actually gets around to advising a colonoscopy. And the tumor then gets detected. By that time, usually it's quite advanced. So any bleeding per rectum, which has been treated as piles or something like that, which is not responding. So it's not piles. So further investigation like a colonoscopy has to be done. Loss of weight. Suddenly you're losing weight or becoming weak and there's a blood test and you see your hemoglobin is low, or lack of appetite. Sometimes cancer presents as jaundice. You can suddenly see very yellow urine. In ladies, sudden loss of weight in the postmenopausal years, or abnormal bleeding, excessive bleeding, bleeding after menopause. These are all signs of gynecological cancer. So it's a bewildering array of symptoms. So it's a logical question for somebody to ask that, Dr. Dara, how will we remember so many early symptoms and signs? It's actually true. Cancer in its early stages gives out symptoms, most cases. But the symptoms are like a normal disease. For example, stomach cancer, will only present as acidity, and the patient will be on Gelusil or Pan 40 or Pantocid for months before an endoscopy is done. So the key is that if there's anything going wrong with your body, which is not settling down in treatment for 2 weeks to a month, obviously you've been visiting a doctor, obviously the doctor has given you medicines, obviously your bleeding, stool in the blood is being treated as piles, you're putting ointments and all that. But if it's not settling down, any issue anywhere in the body, especially non-healing ulcers or sores, then you need to go to a specialist. The specialist may vary with the area where the problem is from. You may not probably first go to an oncologist. Why should you? Except in case of breast, ladies usually don't come to people don't come to an oncologist first. For example, if there's abnormal gynecological issue, they go to the gynecologist. If there's something wrong with the tummy, some acidity or some pain there, pain going behind, then they go to the gastroenterologist. The key is that if there's anything going wrong with your system for 2 weeks to a month, then you need to visit a specialist and you need to insist upon investigations. For example, if your gastroenterologist or your physician has been giving you antacids for your acidity and it's not resolving, you're not improving, then you need to say, doctor, prescribe some more investigations, in which case he'll probably prescribe an ultrasound or an endoscopy. And another important thing is that the tendency of people, which is quite valid, that I will not get myself tested because if I test myself, something will come up. It is important to remember that if something comes up early, then it's likely to be in stage 1 and 2. Instead of waiting, deferring the test or the visit to the doctor and getting detected in stage 3. Because anybody can get cancer. You really don't, cancer doesn't choose. You may have a very healthy lifestyle, still there is a possibility you may get cancer. So you have to be very aware of the early symptoms and signs. Now, God willing, God forbid, if you do, get one of these symptoms and the person goes to the doctor and a scan is done or an endoscopy is done and cancer is found. Next question is biopsy. Something can be seen. Should a biopsy be done? Now, there are many myths that biopsy spreads cancer or surgery spreads cancer. And this myth is prevalent in Eastern India in particular. I was in Tata Memorial Hospital, Mumbai for many years, and I used to see hundreds of patients from all over India. And this belief that biopsy or surgery will spread cancer is prevalent only in this part of the country. If I had asked a patient from Punjab or Kashmir or Tamil Nadu, they would never ask me this question. But patients from Bihar, especially Bengal, Odisha, would ask me that, doctor, biopsy spreads cancer. Biopsy does not spread cancer. Biopsy diagnoses cancer. So unless you undergo the biopsy, unless a biopsy is done, the cancer won't be diagnosed and the treatment won't start. All over the world, the first step on finding something suspicious on radiology or on examination is a biopsy. For example, on a breast, if a lady comes with a breast complaint, the standard investigation apart from clinically examining the breast is to order a mammography and sonography. Sonography, ultrasound of the breast and the mammography. And if something comes up, then an FNAC, which is a fine needle aspiration cytology, or a core needle biopsy, which are both basically needle biopsies. Let's keep it at that. Needle biopsies have to be done. And unless that needle biopsy either is very reassuring and proves there's no cancer, or proves that there is cancer and something needs to be done about it. So unless that biopsy is done, we haven't crossed this stage into the treatment part as yet. So it's very important to remember. I have a theory why the belief is so prevalent in this part of the world is, suppose a cancer is diagnosed, the next thing we do is to run scans and see the whole body. The commonest scan done nowadays is called a PET scan, positron emission tomography, a PET CT. When PET CT is new, before that we used to do CT scan of the head, neck, chest, so basically a whole body scan. Why did we do a whole body scan? Suppose a lady has come with an oral cancer. Why are we checking her lungs? Because we want to be sure that the spread has not happened yet. In a breast cancer, why are we doing a PET CT? In an oral cancer, why are we doing a PET CT? Because we want to check the liver, the lungs. Metastasis does not always show on simple investigations like a chest X-ray or an ultrasound. So this habit separates those patients who are stage 4 already. And so we don't operate on these patients because it serves no purpose. Previously, these scans with this is something we call the metastatic workup. Metastasis means spread to other parts of the body. Metastatic workup means to see if there's any metastasis. So this metastatic workup is routine now, but even when I came back to Kolkata from Bombay, which is like in 2003, it was not done. So as a result, a lot of patients with already existing metastasis used to get operated. And then 6 months down the line or 3 months down the line, the metastasis would give symptoms and the metastasis would get discovered. And the obvious assumption would be that the biopsy or the surgery has caused the metastasis. When in most of these cases, more than 90%, the metastasis would be there from before. So this this thing having happened for many years, probably led to the belief that biopsy and surgery causes spread. So coming back to the question of biopsy, suppose a cancer is discovered. Either a lump is felt in the breast, a mammography, sonography shows a lump, a needle biopsy is done, or there's an ulcer in the tongue or the cheek and it's not healed. And the obvious first person the patient visits is a dentist, and the dentist raises a suspicion and either does a biopsy himself or refers to somebody like me who sends to the maxillofacial surgeon for a biopsy or do a biopsy myself. Or patient has acidity or difficulty in swallowing, and an upper GI endoscopy through the mouth is done, and a thing is found which is obstructing either the food pipe or a mass in the stomach, and a biopsy is done. Or there's blood in the stool and a colonoscopy is done, and we see something inside and a biopsy is done, so the cancer is diagnosed. The next thing, as I said, is a scan, not only of the area of the cancer, but of the other areas where it possibly may have spread, which is again coming back to the same word, metastatic workup. So first we complete the metastatic workup because we want to see that locally, how big is the cancer? Is it stage 1 or 2? Has it invaded to other organs? Has it gone to any other organs of the body? So once these questions are answered, then we know the stage. So as I told you before, if it's small and confined to the organ of origin, it is stage 1 and 2, which is early. If it is bigger than that, but not spread, quite big in the organ of origin, but not spread to other organs, then it is stage 3. But it's gone to other organs, then it's metastatic disease or stage 4. Now comes treatment. Now, as far as cancer is concerned, there are only a few bullets in the gun. There's surgery, there's radiation, and then there's medical treatment. Medical treatment includes mostly some injections which are given via saline, 3 weekly or 2 weekly or 4 weekly, which is called chemotherapy. Nowadays, there are other medical treatments available called targeted therapy, antibodies, various biological agents, immunotherapy, even gene therapy is coming up. So medical treatment is undergoing a rapid expansion. So which treatments are to be used? Now remember, I have made a general classification of stage 1 and 2 and given you the general rules of all solid cancers. But cancer is a very diverse population of diseases, even solid cancers. There are so many organs. Although they are stage 1, 2, 3, 4 rule holds, the biopsy holds, the metastatic workup holds, cancers in different parts of the body behave in different ways. For example, a stage 1 breast cancer will not behave exactly the same way as a stage 1 pancreatic cancer. The relationships are totally different. But more or less, for stage 1 and 2, the important thing is to get the cancer out of the body. So coming back, let's discuss what these individual treatments do. Surgery removes the cancer from the body. In spite of the cancer having been removed and the metastatic workup showing no spread in any part of the body, there is a possibility that there may be some circulating tumor cells in the blood. And they have to be killed in the blood only before they get a chance to get deposited in any other organ. Now, this is where medical treatment comes in, which may be chemotherapy, immunotherapy, targeted therapy, biological agents, whatever. Now, even the surgery has removed the cancer from the local area, but there may be cancer cells scattered in that place. For that, some additional local treatment has to be done. So that is done by X-rays. Radiation is nothing but X-rays. A daily X-ray. So that entire area, suppose for breast cancer, nowadays we don't remove the whole breast. Many sophisticated technologies like breast conservation surgery, oncoplasty has come. So we remove only that part of the breast which contains the cancer. Sometimes we don't even touch the lymph nodes. There are very sophisticated ways called sentinel lymph node biopsy by which we know whether the lymph nodes have to be removed or not. Which means that having the surgery is done, but there may be microscopic cancer cells elsewhere in the breast, not from the primary cancer, but there may be other cancers developing in the breast. So that is where radiotherapy or radiation comes in, which is basically X-ray to the whole area. Instead of removing the whole organ, you're removing part of the organ and radiating the rest to reduce the chance of cancer coming back locally, which we call local recurrence. So the three treatments have their individual targets. Surgery removes the cancer, radiation radiates the adjacent areas to further reduce the chances of cancer coming back locally. And the medical therapy part takes care of the circulating cancer cells in the blood. Now, how much treatment is to be used in which stage? Stage 1 and 2, it's primarily surgery to remove the solid cancer from that part of the body. Some amount of medical treatment because number of circulating cells in the blood are likely to be very low, if at all. And radiation, not everywhere, in some cases to further sterilize the local area. For example, in oral cancer, stage 1 and 2, it is surgery and radiation only. No medical treatment required because chance of circulating cells in the rest of the body are less. Head neck cancer, oral cancer primarily tends to recur locally. Whereas for stomach cancer, it is surgery and medical treatment. Radiation is not given. For breast cancer early stage, it is all three. So it varies according to the organ of origin and the stage. But as a general rule, stage 1 and 2, we aim for cure because most of this I wouldn't say most, but large part of these cancers are curable. So it's surgery followed by radiotherapy and chemotherapy, or chemotherapy, maybe 1, maybe 2. These two together are called adjuvant therapy or additional therapy. Now, for stage 3, in most organs, the cancer is locally advanced, as I told you, and it is too big for removal. Or removal would entail a very large operation, removing other muscles, organs, skin, or parts of the chest wall in the case of breast. So we want to make the cancer smaller so that the extent of surgery has to be less. So more or less, in suppose oral cancer, stage 3 would mean it's coming through the skin. It has maybe the removal would need to remove the whole tongue if it's tongue cancer. So we need to make it small. So in stage 3, medical treatment is done first. We call it downstaging. Chemotherapy or biological agents are used to downstage the disease. And once it's smaller and a less severe operation would suffice, then the next stage is surgery. And then it is more medical treatment, maybe radiation also. So for stage 3, we use all 3 and in high dose. Stage 4 is when it has already gone to other organs of the body. So the metastatic workup picks it up. So there's no point in removing the local disease. For example, in a breast cancer, if the metastatic workup picks up cancer islands in the lungs, metastasis in the lungs, liver, brain, then what purpose is served by removing the breast or the primary tumor in the breast? Because all those sites are acting as primaries. They're all sending their cells out. So removing the breast serves no purpose. So for stage 4, it is only medical treatment. No surgery, no radiation, because both surgery and radiation are local treatments, and local treatment there's no point in doing when the disease is already present in multiple organs. Now, these in a short are how the treatment part of the thing is approached. Now comes the cost and the duration of treatment. Now, surgery also varies, the cost and for example, in breast cancer, the patient goes home the next day. So the cost is lower. In fact, in the entire treatment of breast cancer, the patient has to stay in hospital for only 2 days. The patient gets admitted the day before surgery and goes home the day after surgery. So 2 nights the patient is in hospital, and all the chemotherapy, adjuvant therapy is day care. And radiation is basically, what is radiation? Radiation is X-ray. So it is, instead of a single X-ray, you walk in and walk out. You walk in, get an X-ray done and walk out. Just like any other X-ray, go into a room, you stand in front or lie on a machine and somebody asks you to hold your breath and it takes 5 minutes and you walk out. But the X-ray is daily for 5 days a week for 5 to 6 weeks. So for breast cancer, for example, as I was coming back, it's 2 nights stay for the surgery. All the chemotherapy is day care, which means you come in, you have a 4 to 5 hour saline infusion, you go home. It is done, these injections are done 3 weekly. And radiation is also day care in all cases because you come in, get the X-ray and go out. So the cost for breast cancer treatment is far lower than something like oral cancer, because for oral cancer, the surgery is very large. Part of the jawbone or the upper jawbone may have to be removed. So this amount of tissue removal causes functional, obviously you cannot leave the gap. So in the same operation, it is removed and the plastic surgical team comes and does the reconstruction, which may involve bringing tissue from other parts of the body. For example, when you remove the jawbone or tongue or part of it, then you have to reconstruct it. So what they do nowadays, the reconstruction is much more advanced. It's called microvascular reconstruction. So they pick up similar tissue from other parts of the body, from the surface of the body, skin and fat, and maybe some underlying muscle or bone, to match what has been removed. And they pick it up usually from the thigh or from the leg. And that part of the tissue, they pick it up with its small artery and vein, which is very small, like hairs. Because that part of that artery and that vein is supplying only that part of the skin and fat, which is very small. In place, join the artery and vein to the neck artery and vein to keep the blood supply going to that piece of tissue. This is extensive surgery. The removal part takes around 2.5, 3 hours. The reconstruction part takes 3 to maybe more, depending on how much reconstruction has to be done. Patient has to stay in hospital for 7 to 10 days, maybe more. The eating and everything starting is delayed. There is tube feeding for a long time. And then once the patient recovers from surgery, stitches are removed, patient is eating solid, maybe 4 to 5 weeks, 6 weeks after that, radiotherapy is given. So here the cost of surgery is much more than for breast cancer, because the stay is more, the duration of hours is more. Breast cancer, the surgery is 1 to 1.5 hours. Here the surgery is 8 hours. ICU stay is required. Ventilation is required overnight on the night of surgery. So naturally the cost factor goes up manyfold. Now, question is how much of this cancer the family is going to such an extraordinary length, the family and the patient, of tolerating this assault on the body, the assault on the family's finances. How curable is it? Again, it varies according to the stage and the organ of origin. Usually, stage 1 cancers in almost all organs of the body are very, very curable. The problem is it doesn't get detected in stage 1. For organs which are very much in front of our eyes, which can be checked on a daily basis, like the mouth, the oral cavity, or the breast, the rate of detection in early stage is very high, especially with these annual health checkups. Most of these annual health checkups contain a routine chest x-ray, ultrasound. There's a women's checkup, which is a mammography and sonography. Ladies are also more aware nowadays, so they keep on checking breast self-examination. The breast self-examination video is available on YouTube and other places. So ladies are very aware. So when I was a medical student, almost all breast cancers I see are stage 3. When I was in Tata Memorial for so many years, typically the patients used to come from urban areas, used to have stage 1 and 2, and the patients used to come from villages in Bihar and UP and all, they used to have stage 3. Nowadays, sitting in Kolkata, in a cancer center, the patients I get from the city are mostly in stage 1 and 2 because the ladies are more aware. It's a question of education and awareness, while people coming from the districts usually come in stage 3. So it's a question, how much is curable depends on the stage the patient comes in. So in stage 1, pretty much all cancers are very, very curable. We never say 100%, but it's very high. It's like 85, 90% of patients do get cured. Stage 2, it's less, but still the cure rate is very high. Stage 3 is where most of the cancers tend to present in India, and the cure rate is not good. It's around 50%. Depending on some organs, it's even less. Lung cancer, stage 3, is very poor. Breast cancer, stage 3, much better. It's like that. Stage 4, unfortunately, we can't cure anybody, but it's all palliative treatment or trying to prolong the life of the person for as long as possible. Now, this in a nutshell is the basic thing about cancer. Now, the next question is, how do you prevent it? I spoke to you about how you will suspect that you have cancer. What is your threshold of suspicion when you will go to a doctor and insist upon investigations? Which is any common ailment of your body which is not getting well with time, you should have a high index of suspicion. I've told you about the stages, the science behind the stages, the science behind the treatment. Roughly an idea of the extent of treatment. Can't go into every cancer, but the common ones. Now, how do you prevent it? I can give you some tips, health tips, but there is no guarantee that if you follow these tips, cancer will not happen to you. But yes, the chances become much less. Number 1, tobacco in any form is a strict, absolute no. Be it smoked tobacco like cigarettes or bidis, oral tobacco like gutka, khaini, pan parag, all these packets which hang, chun, lime, betel leaf, pan, supari. Chewing anything apart from chewing gum and soft is bad. So tobacco in all forms, absolute no. The primary cause, if today tobacco is banned, the cancer will be less than half. Cancer incidence in the country. Second is alcohol in moderation, extreme moderation. For example, esophageal cancer, the primary causative factor is alcohol and tobacco together. Third, diet. Take a lot of green leafy vegetables, fish and white meat in your diet. avoid red meat. Red meat is a known cause of colon and rectal cancer. Excessive red meat intake, which is why it's very high in the Western world. For ladies, awareness, breast self-examination, avoid obesity. Avoid obesity because obesity leads to all kinds of cancers, especially breast cancer. Half an hour of exercise every day goes a long way to prevent not only cancer, but lots of other diseases. And a healthy lifestyle and a high index of suspicion for all common problems in your body, which are not going away with time or with regular medication. For young girls, it's very important to have the cervical cancer vaccine. Now, there are some cancers which are virus caused. Now, virus is a very terrible word these days. So, there's a virus called human papilloma virus, HPV, which causes cervical cancer. It's transmitted by sexual intercourse, like the sexually transmitted diseases. And it also causes oral cancer, also by oral contact. Now, HPV, the variety strain which causes cervical cancer, we have a vaccine against that. And we recommend that all young girls between the age of 9 to 13 take the vaccine before they start their reproductive or sexually functional age. Because cervical cancer, in India, in ladies, the commonest cancer is breast and cervical. Breast in the urban population, because the more urban lifestyle, modern life, obesity, all this predisposed to breast cancer. And in villages, it is still cervical cancer in the rural areas. So cervical cancer vaccination will reduce cervical cancer to a huge extent. And in men, the commonest cancers are oral cancer and lung cancer, both tobacco related. So these in short are basic tips which on a healthy lifestyle, which will reduce your chances of having cancer or our chances of having cancer. Now, what about COVID? How does that change everything? Now, we don't know how long this thing is going to last. We in the medical community estimate it to be, nobody knows, but for us, it's going to be 1 year. Maybe it will become much less for you in the population. It will gradually lose severity over time, and maybe by the end of the year, I don't know, but maybe by the end of the year, it will come to a manageable situation. Maybe there will be a vaccine, and maybe it will be available in India. But whatever, we are looking at 2020. But for us in the medical profession who will have to operate or deal with patients, be in close contact, for us it's 1 year. So what a terrible thing which has happened with COVID is that many cancer patients who would otherwise have lived are going to die. Because this entire period of lockdown and everything, investigations have not happened. People have been scared of coming to hospitals. So even a simple investigation like an endoscopy or a CT scan, people say, no, I'm not going to go. So I have had patients I have seen before lockdown. And all this while, they didn't venture out of the house. Although I called and reminded them that please get your tests done, they haven't done that. Now, 3 months later, when they have come, we have scanned them again, and a lot of them have become stage 4. Because cancer is not going to wait. So, if the same mentality continues, we will see a spurt in the number of advanced cancers, the number of people dying from cancer. So, a message is that the hospitals have resumed normal functioning, more or less. And COVID is not the only disease in the world. You can have other things. If we can have other things like heart disease, like non-communicable diseases, other like cancer. So the same rule applies. If you have a problem, then go to the hospital, get yourself investigated. Now comes the very valid fear that if I go to the hospital, I will get COVID. Now, there is not a single hospital in Kolkata which does not have COVID patients. So every hospital has some COVID patients because they're not coming in as COVID in most cases. They're coming in as other respiratory infection, fever, etc., and getting diagnosed as COVID. And once they're diagnosed as COVID and in a serious condition, they can't be moved out. So all hospitals have COVID. But over time, we have developed a SOP or standard operating procedure whereby we are segregating the COVID patients. For now, here comes the advantage for larger hospitals. For example, in Apollo, we have a huge campus. There are 3 buildings. So we have managed to keep the main building and the cancer building completely COVID free because we have segregated the COVID patients to a completely different building. And that also the backside of that building. Same goes for Amri. Although Amri is a dedicated COVID hospital, they have a separate building for COVID. So the normal health activity, people are dying of road traffic accidents. So dying of non-communicable diseases, those treatments must go on. So they have a completely different building for that. So as everybody was caught off guard in the beginning, but now we have managed to get our act together. So the normal other problems, other ailments of the body need attention, and we are gradually getting to treating them in a normal way. Although we have to take complete precautions in the same way. I mean, we have to use the same precautions as they are using in the COVID building because there may be unknown COVIDs amongst us and the patients. But so far, nothing has happened. So that way, so the patients need not be scared about coming to the hospital and getting themselves investigated because more problem is coming from the non-COVID elements than from COVID. So the non-COVID diseases are becoming a huge problem more than probably COVID. For example, in my team only today, a sister had to have an endoscopy and biopsy. So people are having normal diseases and I told them, please go ahead and do it. Because this building is clean, we are all free. So normally the hospital's normal functioning is coming back and normal healthcare has to continue, although we have to be very, very cautious that we don't mix the two population of patients, COVID and non-COVID. That is very important both for doctors and patients, healthcare workers and patients. And gradually, I think by the end of this year, things would seem better. But one big issue is that cancer patients who are undergoing cancer therapy, be it surgery, be it other chemotherapy, etc., are all immunocompromised patients. So for cancer patients, the risk of contracting COVID or not COVID, undergoing complications as a result of surgery or chemotherapy, etc., is more in the COVID times than in non-COVID times, if they get COVID. So it's a more high-risk treatment, both for the cancer patients and for the healthcare workers. But that doesn't mean that early cancers do not deserve a cure or should not get cured or should not get picked up or treated. So that's more or less what I had to say. I've been giving a long talk. I'm sure there are many questions and I'll be happy to take them. Over to you, Professor Doctor.
So, thank you, Dr. Gupta, for such a wonderful and informative lecture. And it has been really a very useful session for all of us, I believe. And we have come across new paradigm of cancer symptoms and treatment. And I'm sure this would really benefit all of us present over here and enhance our awareness about the disease. And I would request now Dr. Gupta to take a few questions. I'm reading the questions from the chat box. The first question is from Dr. Chumpa Mukherjee. If auxiliary growth of breast present in armpit for 25 years or more, can it become malignant?
Lot of women have fatty axillas or fatty swelling in the axilla. That is just fat. It is not cancer. So if there's been something which has been there for 25 years and not changing character. So remember the whole talk I gave. If there's something which is not changing character, then it is very unlikely to become cancer, especially if it's been there for such a long time. But you should, if you haven't already done so, get an ultrasound and a mammography done, which will put this doubt at rest. But if something has been there for a long time and is not changing character, cancer is very rapid. It's a matter of few months. So if it's been there for that long and not increasing in size or not becoming painful or not causing new problems, then chance of cancer is very low.
The second question is from Dr. Saurabh Bose. He's asking that in some cases, cancer is detected at an advanced stage when symptoms appear. So the question is, what sort of checkup or testing can be done to monitor at ages 30 years and above or for senior citizens?
Everybody above the age of 30 years should undergo an annual health checkup, which usually consists of blood, chest x-ray, ultrasound, pap smear, and for ladies, a mammography and sonography. Every lady above the age of 35 should have an annual mammography sonography, should do a breast self-examination, learn it on one of the online sites once a month. And the annual checkup obviously includes a clinical breast examination. So annual checkup including a clinical breast examination and mammosono once a year. For everybody in the population, an annual health checkup. For senior citizens especially. And remember that an annual health checkup is not guaranteed to pick up cancer. For example, if there's a cancer in the stomach or in the food pipe, neither your chest x-ray nor your ultrasound will show it. Only a scan will show it. Now, CT scan is not part of a routine package. Neither is an endoscopy, neither is a colonoscopy. But the annual health package will pick up subtle signs and symptoms which will indicate that probably you need a further investigation. For example, if your annual health checkup, stool examination, reveals blood in the stool which is not visible, you have not actually seen it, but your annual health checkup picks it up, then you need to have a colonoscopy. If your mammosono, although you have not felt anything in your breast, but your mammosono picks up a very small 1 centimeter tumor. Nowadays, a lot of ladies are coming to me, or us rather, with impalpable lesions, which means we can't feel it. So they have been detected by routine mammography sonography. It's not, it can't be felt, and those are less than stage 1. I mean, very early stage 1. So those are almost 100% curable. So I'll again harp on it. Annual health checkup, especially for senior citizens, and breast examination annual, and breast self-examination monthly, with annual breast checkup for all ladies above the age of 35.
There is another question from Shoumita Dash. Is there a high chance that an ovarian cyst can cause ovarian cancer in future?
Now, there are many types of ovarian cysts. Young girls or women who are active in the reproductive age, a cyst up to the size of 4 centimeters is quite normal. Any cyst which is more than 4 centimeters on ultrasound, an ovarian cyst is picked up by a small routine ultrasound. So it's very easily detectable. If it is less than 4 centimeters, it can be safely followed up if the lady is in reproductive age. But if it is more than 4 centimeters, or the lady is beyond reproductive age or nearing the end of her reproductive age, which means her coming near menopause or has achieved menopause, then an ovarian cyst is suspicious. Now, apart from ultrasound, there is a blood test called ROMA. ROMA means risk of ovarian malignancy. So ROMA measures some tumor markers. So combination of USG whole abdomen and that blood test of ROMA can establish if the ovarian cyst can be just followed up, or does a surgery need to be done for it? So there's no, to answer the question depends regarding if there's a high chance that ovarian cyst will become cancer. It depends on the age of the patient, the size of the cyst, and the Roma value.
A question for Amitabh Khan: is the chemotherapy treatment painful? Some patients complain this. Sometimes it is intolerable. Is it true?
Yeah, so of many patients come back to me saying I was very good after surgery. Radiation and chemo, I became very bad after radiotherapy, or I became very bad after chemotherapy. Oral cancer patients typically, after surgery, their quality of life is much better if radiotherapy is not added. Radiation worsens the quality of life significantly. Similarly, chemotherapy. Now, what is chemotherapy? Chemotherapy is basically medicines. For example, the paracetamol that you take when you have fever is called antipyretic chemotherapy. So it's basically a chemical which has been made from some plant or some bacteria. Somehow the term, so anti-cancer drugs is anti-cancer chemotherapy. Malaria drugs are anti-malarial chemotherapy. But the term chemotherapy has stuck with cancer. So it's basically medicines like in any other disease, but these drugs target the fastest growing cells in the body and they stop the cell division. And which are the fastest growing cells in the body? The cancer cells, obviously. And the others are cells lining the mucosa of the oral cavity, the hair follicle cells, and the cells in the bone marrow. So when it stops the division or interrupts the division of the cancer cells, it interrupts the division of these cells also, which is why your hair falls, which is why your mouth gets ulcers, and which is why your blood counts come down. Chemotherapy does make you sick. To answer your question, it does make you sick. One of the principal pain factors in chemotherapy is the need to find a vein, because chemotherapy drugs being very toxic, once a vein is used, that vein can't be used next time. And every 3 weeks, this intravenous thing has to be taken. So finding a vein and keeping on pricking for it becomes a very painful thing for the patient, especially the swelling of the hand and the thrombophlebitis, which follows repeated venipunctures. There's something which has come up for that, which is called a chemo port, which is usually put in at the time of surgery or before starting chemotherapy. It's a small surgical procedure. It is done not only by surgeons like me, but by radiologists also nowadays, which is basically a silicone ball. And it is just like a pacemaker under the skin over here. You can feel it. And there's a small channel leading from it into one of the major veins in the body. So you don't have to prick around for a vein. This thing can be felt under the skin. You can just put some local anesthetic spray and puncture it into that chemo port, that silicone ball, and run the IV saline infusion of chemotherapy, and it goes into the vein. So the chemo port has taken away a large part of the pain component, which was due to the repeated venipunctures and the going on pricking to find a vein and the thrombophlebitis because of that. But even apart from that, chemotherapy does make you very sick. Nausea, vomiting, GI upset. It is not a pleasant thing, and sometimes it is intolerable. Now, again, it depends on the dose. For example, in stage 1 and 2, when you're using chemotherapy, not all cancers need chemotherapy in stage 1 and 2, but some do. Then you're targeting what? You're targeting some circulating cells in the blood, which may or may not be there. So the chemo dose is low. So your side effects are less. But when you're using chemo for tangible, visible disease, like in stage 3 or when metastatic disease, stage 4, then the volume and number of cycles is high. So it is really very painful for the patient and very difficult to take. Many patients can't complete chemotherapy in the advanced stages.
A question for Nasia Fitos. If fibroids are present in a women uterus for more than 10 years, can it become malignant, or it should be get operated? It should get operated out from uterus.
Now, fibroids usually develop during the latter part of the reproductive age and as a lady comes towards menopause. Now, fibroid is a benign tumor, as I told you. It's a benign tumor, but like all benign tumors, it can have the potential to turn malignant if it stays for a long time. That is present with all benign tumors, which is why surgery is advised for benign tumors. There's no hurry, no rush, but people should get it removed. Now, fibroids, if it's present for a long time, can turn cancerous. So for 10 years, if a fibroid has been present, then something should be done about it. Either the fibroid should be removed from the uterus, or if the lady is near menopause, the uterus should be removed.
Question from Shumana Mondol, that is a normal cavity in teeth for long times causes cancer?
Unhealthy dental hygiene causes cancer. So one of the principal causes of oral cancer, apart from oral tobacco, is poor dental hygiene and sharp teeth, which is causing repeated abrasion against the cheeks, called cheek bite, or against the tongue, which is called dental trauma. So poor dental hygiene, a chronic dental trauma can also cause oral cancer. So I won't say cavities in general, not cavities, but poor dental hygiene and sharp teeth over a long period have a tendency to cause cancer.
This is another question from Dr. Shongita Gangopati. Is cancer a hereditary disease?
Yes, good question. Now, although cancer is largely a lifestyle disease because of the lifestyle and the habits that you have, breast, colon, and ovarian cancer do tend to run in families. So if your first degree female relative, for example, if your mother, maternal aunt, sister has had breast cancer, then you have a higher possibility, higher likelihood than somebody who doesn't have that kind of history of developing breast cancer. If your father or anybody else in your family has had developed ovarian or colon cancer, then you need to be more careful. So for first degree female relatives of breast cancer patients, we do a gene study called BRCA1, BRCA1, BRCA2. You have heard of Angelina Jolie. She got both her breasts removed. So she was BRCA positive. So what do we do when we test BRCA in a patient when there is a family history of breast cancer? We know if that lady has a high possibility of developing breast cancer in the future, and she has the option of getting her breast removed prophylactically, preventively, or being very, very careful, maybe undergo a breast examination twice a year, being more vigilant on the breast. For somebody who has a rectal cancer or colonic cancer history, we advise a once a year stool for occult blood to see if that person, and you know, suppose a patient has two relatives who's had colon cancer. So the risk is very high. So we sometimes advise a colonoscopy once every 2 years, depending on the risk value. So these three cancers have a hereditary predisposition. Uneven breast. Is a woman with an uneven breast? No, no, no. But then applies, same rule applies. After 35, breast examination, every month breast self-examination.
And a question from Dr. Jhumpa Mukherjee. What is the chance of getting cancer in a patient under biological treatment, alpha TNF blocker injections prescribed for
autoimmune disease?
Yeah.
No, there is no increased chance of developing cancer. There is no evidence to that effect. And COVID, yes. Any person who's on autoimmune immunogenic therapy for any autoimmune disorder has a higher likelihood of developing COVID. So has to be extra careful.
And is the mortality rate, this is from Tanushree Dash, is the mortality rate of lung cancer patients will be increased amid or post-COVID-19, as we know coronavirus attacks on the lungs?
Mortality rate of all cancers are increased because of COVID, not only lung.
Okay. And this is a question from, I think this question has already been answered, from Dr. Shahbaz Anwar, is all type of cancer is hereditary or
We have covered that.
Yeah. And this is from Shanat Kumar Purkayat. May Hodgkin lymphoma stage A1 return again in future?
Very, very, very unlikely. Very unlikely. It's a very curable disease and is a very early stage. Very unlikely.
And in how much duration stage 1 cancer move to stage 2 and stage 3?
Yes, good question. It varies from organ to organ. Not only does it vary from organ to organ, it varies from person to person. More importantly, person to person. Because you have to understand that cancer has originated from that person's genetic code, from that person's gene. It ultimately boils down to the start and the stop signal. And that start and stop signal is in that person's gene. So the progression from stage 1 to stage 2 and 3 will vary from person to person. For example, in young women, young people, cancers tend to be more aggressive than in older people. So a young lady with breast cancer will move much faster from stage 1 to 2 to 3 than an elderly lady. The more elderly she is, the less faster it will progress from stage 1 to 2 to 3. So we don't know the exact reason for that, but we do know the cancers behave differently in their progression between individuals and across the decades of life. So there is no set answer to that. It's very individual.
So we have many more questions, Dr. Gupta. You please tell me how many more questions will we be able to take?
It's okay as long as your session lasts.
Okay.
Is cancer treatment, this one, is cancer treatment or number of cancer affecting people going to change in the post-COVID era? Yeah, so that's what I already spoke about, that in the COVID era, post-COVID, we don't know. Post-COVID, if everything comes back to normal, then everything comes back to normal. But I think COVID is here to stay for some time now. And the non-COVID treatments should not take a backseat, because what we are calling it the innocent bystander symptom or the collateral damage. So because of COVID, the collateral damage from other diseases is becoming very high, because people are very scared to go to hospitals and neglecting. So the number of heart attack, deaths from cardiac diseases has increased because people are not going to the hospital when they have a chest pain. Cancers, though, is the worst sufferer, because patients are sitting at home with diagnosed cancer, afraid to start the treatment. So I have seen in my patients in these 3 months go from stage 1 to stage 4, not from 1, but from 2 or 3 to 4. And then nothing can be done for that. So cancer treatment definitely is suffering in the COVID era, not least because of fear. So what we are trying to do as oncologists, we are not treating COVID. Obviously, COVID is being treated by the COVID consultants and the respiratory physicians and the other physicians. But as oncologists, we are trying to keep the cancer treatment and the cancer facility completely separate from the COVID part of the hospital. So that this thing that, the increased mortality due to COVID or cancer patients undergoing treatment, contracting COVID, will lessen to as little as possible. And over the last 3 months, initially we were all confused. Over the last 3 months, we have managed to get our act together to some extent. It will improve further in the future.
And the next question, I think this question has also already been covered, that COVID-19 is challenging the non-communicable diseases. What steps hospitals are taking to tackle?
That's what we spoke about.
Yeah.
See, the number of testing has increased. So every patient in my hospital, every patient who gets admitted gets COVID tested. And the antibody test is coming in. We will all ourselves get antibody tested, all healthcare workers, so that the non-COVID part, the 2 non-COVID buildings, which are far away from the COVID building, are COVID-free, so that non-COVID treatment can happen as usual.
And this is from Dr. Biraj Kandi Mondal. Is modern lifestyle responsible for any kind of cancer?
I think we covered that. I think it is a lifestyle disease. How frequent was cancer in your grandfather's time? I'm sure it was frequent, but most of the time it didn't get diagnosed. But cancer is on the rise primarily because we are adopting a more Western lifestyle in everything.
Okay. And what is the chance of getting cancer in a patient under biological treatment prescribed for autoimmune diseases?
No, there is no direct link. There is no direct link. There is no evidence to that effect. There is some evidence, there was some evidence concern about ladies undergoing hormone replacement therapy, hormone therapy for infertility, developing breast cancer. But that is a very tenuous evidence and it has not stood the test of serious research.
Okay, I can't see any more question from here. Is there any more question from the participants, please? Please unmute yourself and ask the question to Dr. Gupta. Is there any more question from the participants? Okay, then thank you, Dr. Gupta, for this wonderful lecture. And I like to thank Dr. Gupta despite his busy schedule. He has found time to grace this session. We are very grateful to him. And I extend my thanks to our principal sir who initiated the entire process, right from suggesting the topic to giving his all possible support and encouragement. And unfortunately, principal sir has got disconnected due to his power cut, and he has conveyed his heartfelt gratitude to Dr. Gupta for being with us. And I owe my heartiest gratitude to all distinguished IQAC members without whose continuous support this program would not have been successful. My heartfelt thanks to all my colleagues and friends present over here. Finally, on behalf of our college, Ddmrm Motijil Rabindra Mahavidyalaya, I'd like to express my appreciation to all the participants for taking time out of their busy duties to attend this seminar. Thank you for your attention. Thank you all. And at last, I want to make one more announcement that we are organizing 2 webinars consecutively, one on 18 June, organized by Department of Geography in collaboration with IQAC. That is on climate change and cryospheric biodiversity. And the speaker is Dr. Punor Bosu Choudhury, Department of Environmental Science, Calcutta University. He has given his kind consent to speak in the webinar. Another is on 20th June, organized by Central Library of our college in collaboration with IQAC. The topic is libraries in the post-pandemic days. Dr. Shopna Banerjee, Acting Dean, Faculty Council for Postgraduate Studies in Education, Journalism and Library and Information Science, University of Calcutta, and Professor, Department of Library and Information Science, University of Calcutta, has agreed to speak in our webinar. And we cordially invite all of you on both of the days, and your presence will encourage us in every possible manner. Thanks once again to everyone for being with us. Thank you all. So, Dr. Gupta, can we end this session?
Yes, please. Thank you. Thank you.
Thank you so much. Shormishta, please end.